Hey, future PTAs. Today we will discuss traumatic brain injury, concussion, Parkinson's disease, and Alzheimer's. Traumatic brain injury is a direct injury to the brain caused by a traumatic force. It could be an open injury, direct penetration through the skull to the brain, or a closed injury where the injury to the brain does not penetrate the skull. So open versus closed is discussing whether or not the skull is open or closed. So there could be an open wound and it still be a closed injury if the skull itself is not damaged, if it's still intact. Some of the examples of an open traumatic brain injury would be like a gunshot wound, a knife wound, skull fragments pushing into the brain, or any type of direct trauma could cause that. Closed injury examples, a concussion, a contusion, which is more so like bruising, bleeding into the area, hematoma, injury to the blood vessels in the area, a lack of oxygen. So hypoxia can cause brain damage, just like with a stroke, a drug overdose, or a chemical change to the brain, near drowning, which would also be hypoxia, or an acceleration deceleration injury, such as what might happen with like a car accident. With the traumatic brain injury, a primary injury is directly caused by the impact. This damages the axons. It causes cell death, which is that necrosis. It disrupts the blood-brain barrier. Remember, the blood-brain barrier is what keeps things like toxins or certain chemicals out of your brain. Even if they're in the bloodstream, they can't cross that blood-brain barrier. And some things that can, or if that barrier is damaged, then they can be allowed to go into the brain and cause more damage or cause an injury. Coop, counter coop. So the coop is talking about the point of impact. So if you hit the front of your head, that front portion of your brain that got damaged would be the coop injury. Counter coop is when the brain hits the back of the skull or the opposite side of the skull and causes more injury. So if I got hit on this side would be the coop. My brain matter would go then slam into my skull on this side, and this would be the counter coop injury. Secondary injury, this occurs in response to the initial injury. It's typically related to inflammation, poor perfusion causing low oxygen saturation or hypoxemia, low oxygen amounts in the blood available to that area. If it is an epidural hematoma, a bleed between the skull and dura, or a subdural hematoma would be a bleed, a venous rupture between the dura and the arachnoid. So where it's located is how it's named. And once again, the primary injury is what happens at impact, and that secondary injury is additional areas of the brain that are injured because of that response, that cellular response, the inflammation, the swelling, pushing in, maybe squishing the brain matter, because again, your brain has nowhere to swell. The skull is very firm and it just pushes into it, causes increased pressure, low blood perfusion, and cell damage or death. Levels of consciousness. So one would be a coma. That would be where you are unconscious, unresponsive to all stimuli. If a coma persists, usually greater than 3 or 4 weeks, and the person's sleep-wake cycle begins to return, sorry, I should have muted my... Okay, if the coma persists, their sleep-wake cycle begins to return, but they're still unable to open their eyes, they can't initiate that voluntary movement, or anything like that, then that can be called a persistent vegetative state. So typically with a coma, their eyes are closed, they can't initiate the movement, and their sleep-wake cycles cannot be distinguished. by an electroencephalograph. So the imaging of the brain can't show whether they're asleep or awake. It's just all kind of jumbled in there together. Once those sleep-wake cycles return, even if they continue to not open their eyes, even if they continue to, have trouble with, not have any active responses to stimuli, things like that, it could be considered after, several weeks, once that happens, a persistent vegetative state. So typically it's more than 30 days after a month of being in that state. Stupor is the next category, and it is a general unresponsiveness with arousal occurring from repeated stimuli. So occasionally with something over and over, they may open their eyes a little bit or look towards that stimuli or something like that, but it takes a lot of repeated stimuli to get any type of response. Continued levels of consciousness. So obtundity, again, they are typically asleep and appearing asleep. They have decreased alertness. Sorry, that was a arrow pointing down. It doesn't look like it's appearing that way here, but decreased alertness and delayed response to stimuli. Once they reach the state of delirium, then they are disoriented, confused, agitated, begin to get more loud because they're not understanding what's going on, but they're starting to wake up. With clouding of consciousness, it's a more quiet behavior. There's still confusion. There's still really low attention, a really delayed response to stimuli, but beginning to calm down and really interact with the environment just a little bit more. Under the conscious state, they're alert, oriented, awake, and able to remember. So those are your levels of consciousness. So conscious is the highest level, and then on down from the ones we started with. All right, with intracranial pressure, remember pressure on the brain tissue can be exerted by the cranium, by the dura mater, by the cerebrospinal fluid, and by the circulating blood volume. Cerebral perfusion is the ratio between your blood pressure and your intracranial pressure, and it determines how much oxygen and nutrients are actually delivered to the brain tissue. So if one is too high or one is too low, then it can cause the cerebral perfusion to change. So let's say your blood pressure is too low, not enough of the blood is getting to the brain, and so you're getting less oxygen and nutrients to the brain. If intracranial pressure is too high, it also keeps the blood from entering those areas of the brain and perfusing the brain as well. So both can decrease blood perfusion. If the blood pressure goes up and not too high, or the intracranial pressure goes down but not too low, it could help increase that blood perfusion. If the blood pressure actually goes too low, yeah, we already talked about that. If it goes too low, of course, you can pass out, and the perfusion is decreased. Or even if blood pressure is too high, it could also cause decreased perfusion, just kind of depending on the state. It could actually cause that hemorrhage that causes a stroke, like we talked about under the stroke lecture. All right, with intracranial pressure, if it's increased, then the cerebral perfusion is decreased. So that could lead to ischemia and cell death. Some of your signs of increased intracranial pressure would be headache, confusion, shallow breathing, high blood pressure, nausea, could even be vomiting. Whereas if your intracranial pressure decreases, which could occur if the blood pressure is too low or if there's significant blood loss, then the signs are typically fainting and death. So whenever our intracranial pressure is too low, we typically faint, because once we lay down and so right now when we're standing up or sitting upright, gravity is, has the most pull on our head, pulling the blood out of the brain. But once we are laying down flat, more blood automatically can go to the brain because the gravity isn't working against it. And so it's your body's way of just taking care of a bad situation. You aren't getting enough blood to the brain, you pass out, and more blood goes to the brain. Assessment techniques. There's the Glasgow Coma Scale, the JFK Coma Recovery Scale, the Disability Rating Scale, and Ranchos Los Amigos Level of Cognitive Functioning Scale. All right, so we will go over the Glasgow Coma Scale. This is a scale that they rate with the lower numbers being like the more severe coma state and the higher numbers being more alert and in the conscious state. So with eyes opening, if they're able to open their eyes spontaneously, then you would give the rating of a 4. If they only open it to someone's speech, 3, to pain, 2, and if they're not opening their eyes at all, it would be a 1. With the verbal response, if they're oriented, it's a 5. If they're confused, a 4. If inappropriate words, which we're not talking about like cuss words and things like that, but things that don't go along with the situation, like, just mumbling or saying something, but it has nothing to do with what's happening in their environment or what they're trying to communicate, that would be a 3. Incomprehensible, just noises, would be a 2. No verbalization at all would be a 1. With your motor response, these are mostly in response to a painful stimuli. So if they're able to obey the commands, that's great. 6. If they're localizing to painful stimuli, that's a 5. If they withdraw from that pain, a 4. If they flex because of pain, it's a 3. And if they extend in relation to pain, that's a 2. If no movement whatsoever to pain, then that is a 1. So level 3 would be a deep coma or, death, close to death, versus a level 15 would be fully alert and oriented. So anywhere in between that can tell you where they are on that scale and kind of how they're progressing. Ranchos Los Amigos Cognitive Functioning Scale. These are all important. These are in score builders. They're also on the boards exam. So I would certainly know the Glasgow Coma and the Ranchos Los Amigos. So level 1, there's no response. The person appears to be in a deep sleep. With a level 2, there's a more generalized response. They react inconsistently and not directly to the stimuli. With a level 3, it's a localized response. Again, they're still inconsistent, but they're more reactive to a direct stimuli. So maybe even be able to, squeeze my hand or blink, and actually react to that versus just occasionally opening their eyes, but not on command or not in response to anything in the environment. Before I move on to the other levels, one of the ways I remember the levels is the first 3 are responses. So level 1, no response, 2, generalized response, 3, localized response. Then there's the feisty 4s because in level 4, they're agitated. So that's the feisty 4s. And then from level 5 on, they become more and more appropriate. And the levels are just based on their appropriateness of their behavior. All right, so here is that level 4. They are confused and agitated and typically irritable, and this is one of the harder stages to treat as well. Level 5, they're confused, inappropriate. Again, it's not like a rude behavior or something. It's more so not responding, like maybe you give them a cup to drink out of and they try and put the cup in their pocket or in their shoe or something. It's not the appropriate thing you do with the cup because they're not recognizing, objects or verbal commands or things like that. They're not as agitated, but they're still confused. Sometimes they can respond accurately to commands, but it's a little more inconsistent at this level. With the level 6, it's called confused appropriate. So they're confused, but they can respond appropriately to simple commands. Whereas level 7, it's automatic appropriate. So they're able to actually start going through routines like brushing their teeth or putting on clothes or taking a shower and participating in some of those routines with minimal confusion. But it's the things that they've already put into memory that are kind of automatic that they don't have to sit here and think, unzip this and turn this. And they don't have to think through the steps. Their body's just going through familiar motions and routines. Oftentimes they'll appear more with some of the conversations and some of their abilities. And they'll be able to, sometimes even carry on like a generic conversation, like, how are you? Oh, I'm good. Things are good. Like without actually processing it on a deeper level. Like they may not even be aware of what exactly they're saying or what exactly you ask them, but they're able to just automatically respond to certain things. Like my dad, of course, my students know that he passed recently from dementia, and when he started, declining, the phrases that he said all of his life were just what he would repeat. So like you could ask him something and he would repeat a phrase that he said his whole life. It may or may not have anything to do with what you just asked him. But sometimes it was like full sentences, or it was, like certain things like, how are you how are you doing? Well, we're doing pretty good around here. How are y'all doing? And that would be like his standard response every time. Like it wouldn't change at all. It was just an automatic response. So sometimes they'll appear a little bit more with it than they really are, but they still will lack judgment. So they're not able to actually clearly understand and interpret a situation and react accordingly. With the level 8, this is purposeful appropriate. So they have functioning memory, they're responding more appropriately to their environment, and able to really live more and more independently. Now, some books stop at level 8 and don't define it any further. And then others defined it more, where level 9 is where the person is able to do what they need to do, their ADLs, with standby assist. And level 10 is that they're able to do it at a modified independent level. So with standby assist, they may need to live in assisted living, or may need to have, a spouse or a loved one close by, so that when they need help with something, that there's somebody close. Versus with modified independent, they may be able to live by themselves, but they're doing things a little bit differently, or a little slower, or, just in a different way than they did at their prior level of function. Now, with the level 8 and up, really one thing to remember is that depression is really high in this category. One of the reasons it's higher in this category is because people are becoming aware of their deficits. Their brain has healed to the point where they are recognizing what's going on, and they're more and more aware of, either on one hand, what's wrong, or on another, this is now my new normal, starting to become aware, like, this is going to be my life. So being aware of that and having resources for somebody to, point them in the direction of getting maybe some counseling or help with that is really key. Because, if any of us got in a car accident or had something major in life happen, and then it changed how the rest of our life was, I mean, that's a really strong uh, reason to be depressed. I mean, it really could cause a lot of feelings for a lot of people. So um, noticing that is key. All right, here are the same ones we went through, a little bit more simplified. Remember, number 1 is no response, 2 is a generalized response, 3 is a localized response, 4 is that confused and agitated, the feisty 4s, 5, confused inappropriate, 6, confused appropriate, 7 is the automatic appropriate, those automatic things going through the motions of things that are familiar, and 8 is your more purposeful appropriate. How we differentiate 8, 9, and 10 is that 8, they may need standby assist, but not even recognize when they need it. 9, they might be able to request it and know when they need help and when they don't. And 10, modified independent, typically don't need anybody standing close by and helping out. All right, some of the considerations for rehab. So if somebody is a level 1 through 3, you want to be really careful how you stimulate or present stimulations. So do it in an organized way that's not overstimulating, that provides minimal cueing. Remember, with a brain injury, the brain has to heal, and it has to decrease stimulation in order to do that. So the more you stimulate, the harder it is to process all the things going on. So even your verbal cues, your tactile cues, the environment, the lighting, the amount of people around, or the external noise, the TV being on or off, music in the background, all those things, can change how much you stimulate the patient. So if you're able to change the lighting, if you're able to turn off any noises that are extra, if you're able to turn off any visual stimuli like a TV, or go in a private treatment room, that would be ideal. And keeping your cueing to a minimum. You want to tell them what you're doing, but keeping it to a minimum would be ideal. And if you can't go in a private room, because oftentimes they might be like in the ICU, which may be a private room, or they might be in with a roommate or whatnot, even just pulling the curtain or something to just block out some of that would be good. Some of the things that we do in this stage are bed mobility, range of motion, caregiver education. In this stage, really, you want to prevent contractures, prevent skin breakdown, make sure that if they begin to heal and come out of the coma or into a more conscious state, that they haven't lost all of their strength and mobility and things like that. For the levels 4 through 6, again, keep those stimulation organized, correct inappropriate behavior. So like if you were to give them a cup and they're trying to put it in their pocket, you could say, no, let's drink, and like show them how to drink out of the cup or something like that. Give positive feedback for good behaviors. With this level, we're typically doing more functional tasks, ambulation training, stair training, ADLs, still educating the caregiver about where they're at and what we expect from them, but more so getting them out of the normal environment. So it may even be, you might be more so in home health versus the inpatient hospital, maybe inpatient rehab. It just depends on the patient themselves, and helping them learn how to do the things again as they're starting to heal. Some of the considerations for level 7 and up are working towards normalizing movement, training the patient on ways of becoming more and more independent. So you want them to build strength, you want them to build, increase function, but you want them to get to a place where they're able to do it independently. And if it requires more assistive devices or adaptive equipment to do that, then in this stage you would start ordering that and getting them as independent as possible. Some of the impairments you'll see with a brain injury are impaired motor function, which might affect their coordination, their balance, their gait, their speech, even their hand use, sensory loss. So they may lose the sense of taste, touch, hearing, vision, or smell. Could be a combination of all of them, things that you don't think about with a brain injury. Oftentimes we think about the bigger picture of like, unable to walk or unable to talk or something, but so many other things are affected as well. Sleep disturbances, insomnia, and fatigue are very common after a brain injury. Medical complications, so spasticity is one after any type of brain injury. You may get stuck in that synergy pattern. Post-traumatic epilepsy is also a common thing to look out for. Hydrocephalus, remember that's that swelling on the brain that you need to watch for. That could be a problem. And then heterotropic ossifications, that's where bone grows in the soft tissue where bone shouldn't be. It could be related to chronic edema, and movement of that area to get the edema out is key in keeping that from happening. More cognitive impairments, they'll have impaired memory oftentimes, may have difficulty learning, may have a lower attention span, problems with focus, difficulty processing their thoughts, problem solving is much harder, reaction time takes a lot longer. They may have decreased organization, planning, decision making. All of these are higher level functions that will be affected if somebody has a brain injury. Language problems, it might be word finding problems or comprehension, difficulty reading, writing. Some of the things that may have come easy to them early in life may not any longer. Memory impairment, so anterograde memory is the inability to create new memories. Post-traumatic amnesia is the time between the injury and when the patient is able to begin recalling events. So oftentimes they'll forget what happened, what brought them to the hospital. They don't remember anything from the time they got in a car crash until, a specific time, and it could be days, weeks after that injury. That would be post-traumatic amnesia. And then retrograde amnesia is the inability to remember events prior to the injury. So that's what they make movies about, waking up in a hospital, not knowing who you are or if you have family or anything like that. That's that retrograde amnesia, and that can really happen. Some of the behavioral impairments, there are a lot of personality changes after a brain injury. Oftentimes, they'll have decreased self esteem, social skills, coping strategies, because remember, that's a higher level functioning that you have to learn over time. Denial, not recognizing their deficits, not, they may not remember who they were before, so they're not able to comprehend how different they are now. Get frustrating more easily, difficulty managing their anger, more self-centered. Think about like a teenager. I was going to say a teenage boy, but that's kind of not nice. But a teenager whose brain hasn't fully developed, and how it's just all about me. And when I get frustrated, I might crash out. I'm not, really in control of my emotions yet because their brain hasn't fully developed and they've not developed some of the skills of being able to, calm themselves or being able to think about, how things affect others or would affect the future. And it's going to be the same here because that brain has to develop those over time as it heals. Disinhibition, your inability to stop yourself from doing the things you want to do. Impulsivity, just if you're wanting, a pen out of somebody's hand, just grabbing it, not asking for it. Reduced insight, not being able to think, outside of the box, think how things affect the future or how things affect somebody else, or how things work together. Apathy, low motivation, often have anxiety, depression, post-traumatic stress disorder, and other psychoses. Some of our treatment considerations: be patient and forgiving. Keep in your mind that outburst or anger or meanness towards you is related to the condition. It is not the patient's choice. That's not naturally how they want to treat you. It's just the condition. Educate the family members on cognitive and behavioral changes. Assess the patient's alertness and orientation every session. That is mainly to make sure that the intracranial pressure isn't increasing, that there's not swelling on the brain that's changing their cognitive status. So usually they're alert and they're talkative and they're, irritable and whatever. And today they're just really fatigued and can barely open their eyes. I would definitely talk to, at the very minimum, the supervising PT, but most likely the physician that is in charge of this patient, to let them know that their arousal level has changed so that they can order more tests and see if they need to, um, you know, change the medical treatment to relieve some of that pressure. Monitor for signs of depression, since this is a very common thing. Make sure you decrease the stimulation. Overstimulation makes it harder to heal. And make it as functional as possible. I've treated somebody with a brain injury before where if you were like, hey, do you want to do therapy today? I mean, it's always a no, like, no, get out of here. I don't want to do it. I'm tired. I don't feel good. But if you're like, have you had a bath today? Or have you gotten dressed? Would you like to change your clothes? Or let's go walk to the bathroom? Or would you like to walk over to the window? Things like that. They're happy to do that. It's all movement. It's all walking and, doing things that you would be doing in therapy anyways. But the more functional, the more connections they see as to why they need to do it, the more motivation and the more likely they are to participate. PTs are typically involved in order to prevent secondary impairments like contractures, pneumonia, pressure sores, to assist with early mobility, and then to teach compensation strategies for ADLs or for mobility, and to decrease the burden of care on the family. Teach the caregivers how to move their patient, how to transfer them, help them, in the wheelchair or whatever they need to do with that. Some of the things we assess as we're treating is their range of motion, to make sure we're locating any tightness before it becomes a contracture. Their gait, their balance, make sure they're not at a high risk of falls. Their skin for pressure sores or skin breakdown. Their level of consciousness and orientation, just to make sure that no changes are happening in their brain that we need to alert someone to. The carryover between sessions, to determine their capacity to learn new things, and then their mood, because you don't want to overstimulate and agitate them further. And you want to just stay calm and, maybe even end the treatment when you need to end it so that they're not leaving really agitated. More treatment considerations: monitor their vitals and all symptoms after having been in a coma for a while. Then any against gravity movement of the head is going to cause the blood pressure to drop. Often the heart rate will get really fast. The vitals will kind of go crazy because they're not used to that. So sometimes like a slant table, or just using the bed itself, like the buttons on the bed, to have them sit up for a little bit to get used to that position. I would do that and make sure your position changes are slower so that you're not causing them to pass out. Make sure you maintain their blood pressure, their mean arterial pressure, which has a high impact on their intracranial pressure, and their oxygen saturation. Those are some of the vitals you need to pay closest attention to. Elevate the head of the bed, make sure they're aligned in a neutral position. That's to avoid causing any type of reflex, if their head is propped up too much or turned to one side. Minimize any painful procedures when possible, and avoid over fatiguing, because their brain needs that energy to heal. Avoid resisted strength training, because you do not want to cause them to do the Valsalva maneuver. Remember, that's exhaling against a closed glottis, or basically bearing down like you would possibly for a bowel movement. That increases your intracranial pressure, so you want to avoid that. So we typically don't use like weights or resistance for quite a while after some type of a brain injury. Allow increased recovery time, and then check with the nurse to make sure they're adequately rested. Ask, when was the last time they had their pain meds, and you want to kind of come to them when they're at a place where they're able to learn and to participate. Do's and don'ts. Some of the things you do: you want to speak directly to the patient. You want to give clear, concise instructions, involve the family members, orient the patient to place and time. So if you ask them, what's today? And maybe they're not alert at all, they can't answer you at all, maybe they get it wrong, you can say, actually, today is, July 4th, 1999. Obviously, it's not that, but whatever day it is. Use their name often, give them more time to respond. So if you say sit up, wait for a little while. Don't just immediately then pull them up and not give them time to process it and try to do it with you. Some of the coma don'ts: do not assume they do not hear you or understand you. So don't talk about the patient in front of the patient. Don't overstimulate the patient. A lot of people have woken up from comas and known everybody that visited them and been able to say, I remember when you said this, or I heard you when you said he's not going to make it. They hear oftentimes, especially if it's a medically induced coma, but even if it's not, they often hear and are aware of way more than we give them credit for. So enter it with the thought of everything. They can hear everything I say, and just tell yourself that when you're treating them. Treatment activities after a brain injury: sitting at the edge of the bed. You can add any type of fine motor task to it: bed mobility, transfers, any type of functional reaching, gait training, coordination activities. You could do bimanual tasks, manipulating with two hands, holding something still while you zip or unzip, doing a button, anything that's functional that they could see why they would need to do it, but that still gets both sides of the body involved, especially if they're crossing midline. That's really important. The rhythmic movements are good. Like repetitive movements are good, reach and back. You could use the PNF and, do hand over hand with the reaching, and then have them do it. So a lot of the things we've done with other patients, you can still do with TBI. You just have to pay attention to what level they're at. All right, switching gears, we're going to talk about concussion really quickly. Concussion is damage to the reticular activating system due to a blow to the head. They may or may not lose consciousness. So the reticular activating system is your network of neurons that extends from the brain stem to the hypothalamus. It's responsible for modulating sensory input and multiple body systems. It includes your sleep-wake cycle, fight or flight behaviors, arousal, consciousness. So with a concussion, there's no structural damage to the brain tissue itself, but there are shearing forces that disturb and disrupt the synapses in the brain. So there still is brain damage on a anatomical level that you may not see as true brain damage in a, CT scan or something like that. The levels of concussion. So one is the least impaired level. So the person did not lose consciousness and their symptoms resolved within 15 minutes. For this, the athlete still needs to be out of their sport and allowed to return only after they've been fully symptom free for at least a week. So they at least need a week of rest. I see in young athletes, I see this not happen time after time. I mean, even last week, I think we had 4 out with concussions and all of them returned in less than a week. Some of them lost consciousness. Like one of the guys, one of our kids were saying he was coming to school not knowing his name. Like they would ask him stuff and he would just be like, huh? Like he was out of it for over a week and he returned to the sport before his functioning returned. Like this is not good. This is not how you treat athletes. They will have issues in the future if you do not allow it to heal. So it's very important. Rest here is defined by a state of minimal stimulation. And increased rest, including sleep. So a lot of people think rest like, oh, I'm laying in bed, I'm watching TV, I'm playing video games, I'm reading a book. All of that is stimulation. Like TV and video games is a lot of stimulation. So in a perfect world, they would be laying in an environment of low light without external input. I mean, you can't do that for a week. Like people would go crazy. But sitting around playing video games is not actually resting the brain. It takes a lot of brain power. So maybe listening to soft music, maybe, you know, getting up and taking a small walk outside, like maybe just sitting, feeling the breeze. I mean, as minimal brain stimulating activities as possible. I would definitely minimize screen use during this time if possible. The next grade is a grade 2, which is a moderate head injury. And this is when the symptoms persist for more than 15 minutes, but they still did not lose consciousness. So they could have poor concentration. They may not remember exactly what happened before the event or after the event, have some memory issues. They need to be removed from the sport. They do need to have a CT scan just if their symptoms get worse, just to make sure there's not like a brain bleed or something. And they are not able to return to the sport until they have been at least 2 weeks symptom free, even with activity. So before they return, they need to do some level of activity to see if it causes any symptoms. And if it does, then that 2-week time period starts over. So a lot of athletes, unfortunately, will lie to you during these times because they want to go back to their sport, especially young athletes that don't get the seriousness of it and are pushed back way too soon. Our grade 3 is anytime there's a loss of consciousness. If they lose consciousness, I don't care if it was for 2 seconds, doesn't matter if their symptoms resolve immediately, does not matter. If they lose consciousness, it is a level 3. They need to go to the ER, they need to have a full neurological workup. If their consciousness is altered, if their decreased mental status persists, if it continues, they would need to be hospitalized. For someone who has a grade 3, if they lost consciousness whatsoever, they need to be out of their sport for a minimum of a month. You don't see this happening, you need to see this happening. A minimum of 1 month of being symptom free before they can return. So if they're continuing to have headaches, if they're continuing to have blurred vision or dizziness or just random nausea spells or anything like that, they cannot return to the sport. They need to be 1 month symptom-free before they return. And if there is a loss of consciousness, then there was some type of axonal injury likely. And in some cases, it could lead to a coma. I mean, it can be very dangerous. So, in this situation, again, the same type of rest as with level one, as little stimulation as possible, and a month symptom free before they return to a sport. All right, Parkinson's disease. This is a hypokinetic disorder. It's characterized by increased activity of the basal ganglia. The basal ganglia is what sends out an inhibitory signal to your body to stop movement. And so when it has an increased activation or it's more active, then it leads to the body constantly getting inhibitory signals. So your body is constantly being told, don't move, don't move. So even when you're saying reach, there's another signal saying, don't reach. Low dopamine levels allow for that constant inhibitory message to be sent. Dopamine is necessary to send nerve impulses between neurons. So it's required for motor control. It plays a key role in neuromodulation, in motivation, cognitive functioning. So when the dopamine levels are low, then all of those things are affected. The presentation, typically freezing of gait, shuffling gait, difficulty initiating movements, doll face, which is just like a lack of facial expressions. It kind of looks the same, whether they're happy or excited or sad. Frequent falls, stiffness throughout the body. So that's one of the reasons there's falls. There's just literally stiffness, typically a shuffling gait, which will also make you more likely to fall. Pin rolling hand trimmer. So it starts out often like that, like they're rolling a pin, um, and kind of turn into the whole hand trimmering like that. Feel large. So their brain is still saying, stretch overhead, but their body is doing a small movement. Kyphosis, spine mobility, for head posture because of the kyphosis, and it's called Parkinson's. So treating Parkinson's patients, LSVT big therapy, it emphasizes large movements to increase movement initiate and magnitude. So it's like big, huge movements and like big slaps and sounds in between to kind of increase the level of alertness and push the patient to push their body to move in the way. So as they're given this huge command to their body parts, then the idea is the person's able to do a more normalized movement versus a little small movement. Gait training with emphasis on turning, on backing up, on frequent stops and starts, on walking between converging lines. Like if you put tape on the floor in the shape of a V, that will often trigger freezing of gait. So if you do that, then oftentimes you can train them to move past the freezing of gait to be able to feel that inhibitory message and then still continue to walk. Walking between objects, same thing. Using a metronome or music can be very helpful with helping them walk, but you don't want to use it all the time because then they may not be able to do it when there's not music on, or a metronome like that, beat that keeps a consistent beat. Balance activities, postural control, like sitting at the edge of the bed, standing back extension, anything to get them in a more upright and to get them to lift their legs higher and do walking in a safer way. All right, with Alzheimer's, this is a progressive neurodegenerative disorder. It results in deterioration and irreversible damage within the cerebral cortex and subcortical areas of the brain. So there are plaques that develop, there are tangles in the neurons that cause damage to the brain itself, causing this degeneration of the brain. It involves acetylcholine transmitters that deteriorate within the brain. There's those plaques, and then the neurofibrillary tangles that cause further damage. A true diagnosis of Alzheimer's, although many people are diagnosed without this, is would have to wait until an autopsy after death. So an autopsy of the brain is how you would truly diagnose, and you would see those plaques and those tangles, but symptoms can most often point to whether it's Alzheimer's or other types of dementia. All right, the etiology is unknown, but some of the causes they believe are low levels of neurotransmitters, high levels of aluminum in the brain, genetics, autoimmune diseases, abnormal processing of amyloid, a virus possibly. The risk increases with age, and it's more likely in women. Some of the symptoms initially, there's difficulty learning new tasks, difficulty concentrating and remembering just small things, forgetting little things, forgetting, where you put your shoes or where you put your keys, things that all of us do, but happening more and more often, um, and more severe. Later, there's a loss of orientation, difficulty finding words, depression, poor judgment, rigidity, bradykinesia, that's slow movements, shuffling gait, impaired ability to perform self-care like dressing, feeding yourself. In the end stage, there becomes a severe intellectual and physical destruction. So their whole body just starts to deteriorate. Incontinence, functional dependence, not really able to do anything for themselves, inability to speak even. And most of them at some point get to a place where they stop eating and or drinking. And that is typically how someone dies from Alzheimer's, is that they no longer eat or drink. Some of the treatment, there is not a cure. There are some meds that can inhibit acetylcholinesterase, which decreases the progression and or the controls behavioral changes. PT focuses on maintaining function and caregiver education. But most people with Alzheimer's, they will require a full-time caregiver at some point. So long-term care facilities are very common. A lot of times there's personality changes, there's aggressive behaviors, there's other complications that just become too hard on the caregivers to continue caring for them in their home. So they're often transferred to long-term care facilities. All right, that is it for us today, and I hope to see you in the next lecture.